All right, hey guys, this is Mike Jenko, and I'm here with Chris Maples,
Hey, kid.
and we are going to do a quick update on angioedema. And this is based on a talk that Chris and I gave earlier today at Obici's Grand Rounds. And I thought it was a pretty good slide stack. I learned a lot when I put this together, and so I wanted to share it with all of you. So during this talk, we want to talk about the different types of angioedema. We've broken them down into basically 6 different categories, which sounds like a lot of different angioedema, but I realize it actually is important to know what you're dealing with, which is probably a good motto in life in general.
Yeah, I prefer to do the exact opposite and just make it up as I go along.
So, well, different strokes. Wanted to review evaluation and management of angioedema in the acute care setting, and then also wanted to review some of the newer treatment options for hereditary angioedema and ACE-induced angioedema. So I'd like to start off with a quick case. This is a case that we had at one of our facilities. It was a 65-year-old female who woke up one morning with tongue swelling and difficulty swallowing. Now, she had been put on lisinopril probably about 3 or 4 months prior for hypertension. She was describing a sensation of throat swelling, but she really didn't have any other symptoms. Vital signs were really unremarkable. I mean, she was a little hypertensive, but she hadn't taken her medicines that day because of the throat swelling. The provider that saw her thought that she looked mildly distressed. She did have marked swelling of her tongue on exam, but she wasn't having any stridor or any drooling, and he was able to visualize her pharynx on exam. Started her on IV Benadryl, Pepsid, and Solumedrol. Obtained a chest x-ray, EKG, and basic labs, which didn't really matter in this case, but which we always seem to do on everybody, and immediately called the ICU attending. This lady had actually checked in a little after 8, and by 20 after 8 he had put the call out, and the ICU attending, I think, called back within about 10 minutes. And after discussion and recognizing that they didn't have the resources they needed to potentially manage her airway, they transferred her to another hospital's ICU. She arrived at the ICU. I mean, she was out the door before 9. She arrived at the ICU about 9:15, where she was seen by the attending. She, over the next half an hour or so, developed increasing difficulty breathing, dropped her SATs into the mid-80s. That attending called a second ICU attending, and they made multiple attempts at fiber optic intubation, but they were unsuccessful, and ultimately she had to have an emergent tracheostomy at the bedside. So with that as a backdrop, we wanted to talk about some of the different forms of angioedema, and unfortunately that type of case is not unusual.
No, sadly not. I think you said it before, there's nothing more anxiety-provoking than bed 6 has swollen lips and tongue.
Right,
us.
And is drooling.
So, by way of definition, angioedema is an acute, episodic, non-localized, non-symmetrical swelling primarily of the deep dermis. The actual epidemiology of it is hard to pin down due to different types of ICD-9 codes, but it's thought to be about 80 to 110,000 visits to the emergency room a year, and about 25% of people will experience some form of angioedema or urticaria in their lifetime. Recent review of some years of angioedema deaths from 1979 to 2010 showed that there was about 5,700 deaths in which angioedema was listed as a contributing cause. What's interesting about this is that hereditary angioedema is actually going down as a cause of death in angioedema, whereas all-cause angioedema deaths are going up, and it's possible that this is related to the number of ACE inhibitor prescriptions we're writing. And then the only other thing we'll mention here is that the angioedema can occur with anaphylaxis, it can occur without anaphylaxis. Angioedema can occur without urticaria or can occur with urticaria. And some of these physical findings can clue us into the nature of the angioedema itself. So, 2 different types of angioedema. Angioedema, there on the right side of the screen, is thought to be a histaminergic response in one brand and then a bradykinin response in another brand. So that is the histaminergic angioedema versus the non-histaminergic angioedema. The histaminergic angioedema is our traditional mast cell IgE-mediated histamine release. Antigen cross-links the IgE or is directly degranulated, and you end up with histamine, which causes vascular permeability and plasma leakage. The non-histaminergic angioedema, the classic one being hereditary angioedema, is a bradykinin problem. And here you'll see that the C1 protein, which is a protease, plays a key role in the production of bradykinin, involved in the movement of prekallikrein to kallikrein, and then the cleavage of high molecular weight kininogen to bradykinin. That's a lot, I know. Just take it in. Take it in. Conversely, there is a C1 inhibitor protein that downregulates that process. Everyone that is aero-averse can now wake up. So, the bradykinin-mediated types of angioedema: classically hereditary angioedema, ACE-induced angioedema. There are other drugs, NSAIDs, PPIs, beta blockers. And then acquired angioedema, which is usually paraneoplastic or neoplastic. And then more familiar to us is the histamine-mediated angioedema. These are the allergic angioedemas, and the most common type of angioedema, which is the idiopathic angioedema. So hereditary angioedema is rare. We know that about 1 in 10,000 to 1 in 50,000. CHKD has a panel of about 20 kids that they treat actively for hereditary angioedema, so it's in this area, and it's possible you'll see these patients. It's generally inherited, autosomal dominant, although about 25% of these are de novo mutations. Again, diagnosed in childhood and young adults, precipitated by things like trauma, puberty, surgery, stress, cold, these types of things. And there are primarily two types. Type 1 is associated with a low level of C1 inhibitor protein, and type 2 has normal levels of C1 inhibitor protein, but that protein is non-functional. We'll mention there is a type 3 that has normal levels and function that is being increasingly well described.
Now, I would just interject here that if you happen to see one of these kids in the emergency department and mom tells you this is how we do it that way. Okay, the parents and the patients that have hereditary angioedema generally have a real good sense of their disease. They know what works, they know what doesn't work. And so if you see them and they say, you know, this is the medicine we usually use, this is the dose we usually use it in, I would make every effort to follow their lead.
That's a great point, Mike, especially because the earlier you use some of these very specifically acting medications in these kids, the better they do. You can avoid ICU admissions and intubation. So here's the one that plagues us, the ACE inhibitor angioedema. 30% of angioedema seen in the ED. Feels like more than that, doesn't it, Mike?
It does, yeah, I would say.
What would you say?
90%.
92.1%.
92.5%.
Yes. But really, the literature shows that it's probably less than 1% of patients on ACE, all told. But since we're cranking out the ACE inhibitors, 40 million prescriptions a year, this is starting to become the most common reason people present to the emergency room for angioedema. Who's at risk? Well, African Americans, women, and patients on immunosuppressants. 55% of the people that die from angioedema are African Americans. And this is as a result of the decreased metabolism of bradykinin. So the angiotensin converting enzyme degrades bradykinin. It's one of the pathways. And if you inhibit that enzyme, I'm thinking that increases bradykinin.
Yep.
Now, the other point is that most commonly, folks will get this within 90 days. It says 30, but it's more commonly 90. And you can get it at any point in the treatment on ACE. So 4 years in, you can get ACE-induced angioedema for the first time. And you're at risk for it up to a month or so after discontinuation of the ACE. That's fun.
Yeah.
So a couple other types of angioedema. Acquired angioedema is rare. It's onset in an older population. And these are people with underlying B-cell lymphomas, most commonly CLL, non-Hodgkin's lymphomas, multiple myeloma. And then sometimes in folks with autoimmune disease, you can get autoantibodies to C1 inhibitor. Basically, it's an upregulation of complement at all times, and you end up using up your C1 inhibitor, creating that nasty bradykinin we talk about so much. And then a couple others, allergic angioedema. This is our traditional IgE-mediated histamine trigger, very responsive to epinephrine and antihistamines. And as opposed to the bradykinin-mediated angioedemas, this tends to onset pretty quickly after the exposure, rather than a slow, insidious onset. And then finally, the most common type of angioedema, which is the I don't know why it's happening angioedema. Really any age, but 30 to 50 years most common. The good news is that most of these are responsive to longer acting antihistamines. And if you're going to pick one antihistamine to put somebody on, cetirizine seems to be the most effective long-term one. Your turn, Mike.
So when we look at when we evaluate patients with angioedema in the emergency department, we generally try to identify whether we think it's mediated by bradykinin or histamine. Within the group of bradykinin mediated, you're looking at the hereditary angioedema. Most of these folks have been diagnosed before they come to the emergency department.
I like that. That's
Yes,
nice.
it's
when
always
they were
nice
able
to have
tell
the
you.
answer up front.
That's the
Yeah.
that's the patient population I excel
Yep.
at.
Acquired angioedema, it may be first-time presentation, or you may have somebody who's had several episodes of angioedema and doesn't know what the cause is. ACE inhibitor angioedema, obviously you're going to see more common in the African-American population and in females, and oftentimes will improve after the drug has been discontinued. However, these patients can be at risk for recurrent angioedema for up to a month afterwards, or sometimes even longer after the ACE has been discontinued. Within the histamine-mediated angioedema, you're looking at allergic and idiopathic. Generally, you're going to have a well-defined trigger in most allergic cases. You will have some urticaria, obviously, with those. Idiopathic may be a little bit harder to identify, but a lot of times you can use the history to help narrow down which you're dealing with. And then obviously you can use that information to tailor your treatment. Location of attacks likewise can give you some information about what you're dealing with. In hereditary and acquired angioedema, you may see some abdominal component, and that's due to the increased vascular permeability caused by the bradykinin, causing accumulation of fluid within the bowel wall, leading to pain.
So
and
these
discomfort.
kids can look like acute appies, right?
Right, they can have pretty significant abdominal pain, guarding, rebound, and there are some case reports of kids actually going to the OR for an X-lap
Ooh.
when they actually have angioedema. So
Embarrassing.
yeah, put that on your list of things to another thing to worry about.
What if they take the
kids.
appendix anyway at that point?
I don't know. I probably would.
Yeah.
So,
It's vestigial.
yeah, it is. ACE inhibitor angioedema is going to be predominantly the face, lips, tongue, and all of these obviously can involve lips, face, tongue, and the larynx. Allergic and idiopathic angioedema, well, allergic is going to have hopefully some urticarial involvement to help clue you into that. And so that, again, is a way that you can differentiate what you're dealing with. When they present to the emergency department, oftentimes you'll have normal or minimally abnormal vital signs. As airway obstruction progresses, they'll develop tachypnea and hypoxia. And it's important to remember that in some of the more severe cases, they can actually third space a fair amount of fluid and could present shocky. So if they're tachycardic and hypotensive, you may need to give them a fair amount of fluid to resuscitate them. The key part of the physical exam is going to be the head and neck. You're going to see a fair amount of edema, usually lips, cheeks, eyes. Obviously can involve the tongue, the pharynx, the hypopharynx. As the airway progresses as the airway obstruction progresses, you can see some hoarseness and some voice changes. They may be drooling, you may see them tripoding, and they may develop stridor and complain of dyspnea. So all things to look for and all things to be wary of. The photo that we've included, I think, is a pretty good representation of what we'll see in many cases when folks present with hereditary or ACE inhibitor-induced
Mike, I
angioedema.
will tell you, my sister's a little upset you didn't get a disclosure of information form.
That was an oversight, please.
She's gonna
I'll make it
she's
up to her.
gonna Sue you.
I'll make her up to her on Saturday night.
Oh, that's not right.
So this is a movie that we got from YouTube, and I'm hoping that this plays without any difficulty. And I think it offers a pretty good visual representation of what some of these patients look like when they first present. You can see that lip swelling. In this case, it's fairly symmetrical. It seems to involve predominantly the lower lip. I have seen plenty of cases that have involved the upper lip, and I've seen plenty of cases with asymmetric swelling. So don't let that throw you for a loop and make you think it's something other than angioedema. This particular patient happened to be ACE inhibitor-induced angioedema, and and I think is a good representation of a fairly mild case in this situation. Now, the next video is someone who has a little bit more advanced angioedema, and I want you to focus early on in the video on his lips and his face and what that looks like, and then contrast to what his tongue looks like when he sticks his tongue out.
Can I tell you in this video where my sphincter tightens up a little bit? Exactly
Yes,
when?
absolutely.
Okay, get ready.
Yeah.
Okay.
So
Things are fine.
look
I'm
at his
feeling good.
look at his face.
I'm feeling fine. And
oh, there
wait.
it is.
A little bit tight. My sphincter's. Oh wait, no, there's.
Now the drooling starts.
Oh yeah, my sphincter is
So
quite closed.
this video was actually taken by an emergency physician out of the Georgia health system, and I have to say this guy has huge cojones, because I would not be videotaping this. I would be calling the OR and getting him ready for his double setup.
I just had a little bit of an accident.
We're going to pause for a moment while Chris changes his pants.
That's not good.
So in physical exam, you can see some skin changes in both the bradykinin-mediated and the histamine-mediated types. With the bradykinin-mediated, it's frequently going to be a firm swelling. It's going to involve the arms, legs, hands, feet. Oftentimes, patients complain of tenderness, and it's usually a non-pitting swelling. Within the histamine-mediated, the skin changes that you're most likely to see would be urticarial-type changes, and that's the classic urticaria. Here's some pictures, I think, that show the skin changes you see in the hereditary angioedema quite well. You can see the asymmetric swelling of that patient's hands, and then the asymmetric swelling of that patient's feet. And then on the left side of the slide there, you can see fairly classic-looking urticaria. Generally speaking, our ancillary studies aren't going to be diagnostic in the emergency department. We frequently will get labs just because that's what we do, it seems like, but we really don't rely on those to make the diagnosis. If you are thinking clearly, and if you decide that this is someone who's going to be able to go home with follow-up, or maybe they haven't been diagnosed before, you may want to consider sending a C4 or a tryptase or one of those type tests, just to help our allergist colleagues sort out which type of angioedema they have. But in general, it's not going to be very helpful to us in the emergency department.
I will say that the allergy folks, they do like the C4 levels, because that can really help them differentiate hereditary angioedema from other types in these kind of non-specific presentations.
And I think when you draw these, they have to be handled fairly specifically after the blood's been obtained. I think that there's some have to be on ice or something. So make sure that if you're going to do that, make sure that you call the lab and coordinate how those lab samples are transported and such.
I think the tryptase has to be transported in a ostrich egg with a careful gloved hand.
Gloved hand. Is it a specific type of glove?
It's a white glove.
White.
Thanks for
I
bringing
thought maybe
that
a
up.
Michael Jackson glove.
It can be bedazzled.
Bedazzled.
I don't know.
Wonderful.
I'm making this up.
The key, I think, the key ancillary study in the emergency department, if you're worried about airway involvement, is the fiber optic laryngoscopy. Other studies to look at their airway, CT, X-ray, and such, really aren't very reliable. Unfortunately, the fiber optic laryngoscopy is not something that a lot of us practice with any regularity, and so I think among ED providers you're going to see variable degrees of comfort with that, and that's where consulting our ear, nose, and throat colleagues or our intensivist colleagues.
I will tell you,
important.
I have a low threshold for getting someone involved that can look at the larynx, because that's really where it goes down. Supraglottically and larynx.
No, I agree, and I take the same approach, and I think that's probably a good idea in most cases. Where we are going to earn our money with these patients is in airway assessment and management. All of these folks should have IV, O2 monitor, pulse ox. There is a school of thought that you ought to put them on capnography as well. Unfortunately, changes in pulse ox, changes in their capnography are often going to be late manifestations of progressive airway obstruction. And so my hope would be that, sure, it's fine to use those, but you're not relying on those to decide when to start managing their airway. Generally, if they get to a point where they're dropping their pulse ox, you really should have managed that patient earlier, in my opinion. Steroids and antihistamines, again, are going to be very effective in the histamine-related types of angioedema, not so helpful in the bradykinin-mediated angioedema. In reality, we give those in our day-to-day practice to everybody that has angioedema on the off chance that it could help. In someone who's particularly symptomatic, we will also give IM epinephrine. This is a slide with a lot of arrows that is basically an algorithm from SAEM on how you manage these patients, but basically breaks it down into, do they appear to be histamine related, or do they appear to be hereditary non-histamine related, and how you would manage that. Airway evaluation is going to depend largely on your clinical gestalt and objective evaluation. There is, even within our own group, I think, a little bit of differing thought on these, in that there are some providers who feel that early and very aggressive airway management is appropriate, whereas others will try to treat first and see how they respond. I think that a lot of it is going to depend on the specific situation, what resources you have available to you at the facility you're at, and how comfortable you are with your crash airway skills. And again, I can't emphasize this enough. If you're unsure of the status of their airway and you think that there could be some laryngeal involvement, then you need to visualize that in whatever way you can at that particular facility. When we talk about airway management, I think certainly all these folks ought to be on O2. If they deteriorate, you can certainly use a nasal trumpet or a bag valve mask to help temporize things while you are setting up your other equipment, but I don't think that those would be considered a managed airway in any sense of the term.
If only.
Yeah. Generally, when you're talking about these folks, you're talking about endotracheal intubation, and because the airway anatomy can be so distorted, and because there's a high rate of failure when trying to endotracheal intubate these folks, you need to have a rescue plan, and in the emergency department, that means a cricothyrotomy. There are other types of airways out there that some of our providers have gotten very good at using. Certainly our EMS personnel are very good using the supraglottic airways when they have a failed airway in the field. Unfortunately, I don't think that can be considered a definitively managed airway in these cases. It might be tempting to try an intubating LMA, but because of the supraglottic swelling that is frequently present, you really can't be sure that you're actually going to be successful. Same goes for blind nasotracheal intubation. I don't know that anyone even does that anymore.
Well, there
Which
are a
is probably
couple
a
of sort
good
of like
thing.
experts in the field that I think we still have in our group, but it is a dying art.
Yeah, and that's probably a good thing. It's probably an art that needs to die in this day and age. So I think you're left with endotracheal intubation as the gold standard, in my opinion. Now, when we intubate folks in the emergency department, oftentimes if we feel that they have a very low chance of difficulty, if we feel that it's an airway that's going to go pretty well, we will paralyze them. In this population, I would very strongly caution you not to paralyze these folks. I think you need to go with the awake intubation. Using ketamine or etomidate to sedate them. Most of the airway experts are recommending the ketamine in these cases. I think doses of less than 1 mg per kg are going to allow them to maintain their own airway while you're doing the awake intubation.
It's almost like ketamine was made for this.
Yeah,
You know,
I
just
agree.
another fantastic use for
Yeah.
ketamine.
Yeah.
I don't see any other drug even coming close.
When you're doing your awake intubation, you want to make sure that you've got good anesthesia, local anesthesia on board. If you have time, if you think of it while you're setting up, you can give them a dose of rohypnol. I'm sorry, not rohypnol. Robenol. Rohypnol would probably be good for your induction, and anything that you wanted to do afterwards, Chris.
Okay,
But,
the year was 1992. Let me walk you through it.
so I think we'll just go with glycopyrrolate in this case, and then
Calling Dr.
atomized
Freud.
atomized 4% lidocaine with some epinephrine or tetracaine, I think will help with real good local anesthesia. I know some providers will use lidocaine jelly and some Afrin spray, and that is certainly good as well. And then you're going to want to visualize either with video laryngoscopy, so your CMAC, your glide scope, or you're going to want to use a fiber optic nasotracheal method. I know that most of our providers are probably more comfortable with the video laryngoscopy. Again, would caution you, if there's any significant degree of tongue swelling, you're going to have trouble manipulating the tongue in the mouth with that, and you're going to want to go the nasotracheal route instead. Think back to the video of the patient with a real swollen tongue. You can only imagine trying to put a CMAC in there
Good
and
God.
then manipulate an endotracheal tube or a bougie or a suction or any of that would be very, very difficult. Having said that, there are some folks who've never done a fiber optic nasotracheal intubation and may be very, very comfortable with the video laryngoscopy. And so if it's a really difficult airway, you may want to try the method that you're most comfortable with first. Again, understanding that you need to have a backup for failed airway. Now, in the emergency department, our backup is going to be the cricothyrotomy. In this case, there really is not a good bridge device that's going to be a suitable replacement for that at this time. You want to make sure you've done your double setup prior to attempting your awake intubation. That means identifying your landmarks. You may want to even put a big X over the membrane, prepping that neck and doing local anesthetic, having your tray set up so all your equipment's ready. There are a couple of different ways that cricothyrotomy is taught now. One of the more common ways is the 4-step method, and that's the way they taught me when I was in residency, and I think they still teach that now. We have a number of kits in our area EDs that allow for something for the Seldinger technique, actually, and something a little bit different, but again, another alternative to use. And it doesn't really matter, I think, what method you use as long as you get the tube in.
Yeah. Mike, I just came up with the next tattoo I'm going to get. Just so everyone knows.
I
when
don't
it's time.
think that you're the type of person they're going to have a hard time identifying landmarks in. Yeah, unfortunately, the people that end up needing this frequently are the ones that have the difficult landmarks, and so you need to really make sure that you identify those well before you get to that point, if you can.
So what do we have besides steel and plastic? Well, there's a couple new drugs that are coming out, or have come out in the last 5 years that look really good for the bradykinin-mediated angioedemas. So, summary slide, and I will say that all of these agents are FDA approved for the treatment of prophylaxis, the treatment of hereditary angioedema, and there's increasing data, case reports, and a couple studies that show that they may be useful in other types of bradykinin-mediated angioedema, most specifically the ACE. So Berinert and Cinryze are plasma-derived C1 inhibitor proteins. So they basically pool a bunch of plasma, pull out the C1 inhibitor. They're given as an IV infusion and have some of the same side effects that all of these blood-derived products have. Berinert is FDA approved for prophylaxis and treatment of hereditary angioedema, whereas Cinryze is just prophylaxis, although used off-label very commonly for the treatment. These are the agents, to some degree, that the patients with hereditary angioedema are going to come in and they're going to say, this is what I get and here's how much I use. Berinert is carried at Obici and I think at most of the Sentara facilities. Is that correct?
Yeah, we've got it at Bell too. I confess I don't know about Norfolk or some of the beach-based facilities.
Oh, chime in.
Yeah.
And then there are two others that are looking increasingly good for ACE inhibitor angioedema potentially, but are FDA approved for hereditary angioedema. Kalbitor is a plasma kallikrein inhibitor, and I'll point you back to this slide that basically demonstrates
Last
kallikrein.
slide with arrows, we promise.
Maybe another. No, I think that is the last one.
Yeah.
And then Firazyr, which is a downstream mediator of bradykinin action by blocking the bradykinin 2 receptor. So it's an antagonist to that. Nice thing about these is they're given sub-Q, and they don't carry a lot of the side effects that the Berinert and Cinryze do, although there can be some hypersensitivity to Kalbitor. Ruconest is another recombinant, or is a recombinant C1 inhibitor, but isn't FDA approved yet in the United States. So a couple of studies that look at the use of these medicines off-label for treatment of ACE-induced angioedema.
And I would just point out to our EPT colleagues, check out the second author.
Oh, look at that guy. Look at that guy. As it turns out, Dr. Graffio is a angioedema badass. Did you know that?
I did not know that until I started preparing this.
Yes, he's the go-to guy.
Basically everything that every resource we used in this.
So I am a little reticent to even talk about this study because, he's the man. But here it is. February 2015, Annals of Emergency Medicine. Phase 2 double-blind study sponsored by the makers of Kalbitor looking at the use of this medicine in ACE-induced angioedema. 79 patients enrolled, 76 studied. Most of these were mild to moderate. They got placebo versus varying doses of ecallantide, which is Kalbitor. Unfortunately, this was a negative study. No difference at 6 hours. Majority of both groups met discharge criteria by 3 hours. Dr. Gaffio will wax about the reasons for this, although I think it's possible they got a hold of a group that was going to resolve anyway, and that this medication for ACE-induced angioedema, it's not the end. Anything else on that one? More recently, there was a New England Journal article that looked at icatibant. This is the Firazyr, randomized trial of icatibant in ACE-induced angioedema. This is a multi-center, double-blind randomized trial out of Germany. They looked at 30 patients. They ended up enrolling 27 of them, and they basically got Firazyr versus standard therapy, which was steroids and antihistamines. There were some impressive results here. The median time to resolution was 8 hours in the icatibant group versus 27 hours in the standard therapy group. About 5 of the patients in the icatibant group actually had resolution in half that time, 4 hours. And then the time to onset improvement was 2 hours versus 11 hours. Now, there are problems with this study. I would invite you to look at the study design itself. This may not really be as good as it looks, but there may be a patient population that, if given early enough and if they are severe enough, respond very nicely to these medicines. And then finally, just a quick note on Berinert. This was one of the studies that got its FDA approval for hereditary angioedema, and it looks pretty good. The reason we bring this one up is really just a general theme of the earlier you use these medicines in these entities, especially hereditary angioedema, and probably the ACE ones as well, the more effective they are. So waiting, as Mike said, for the mom to yell at you to stop using steroids in her child with angioedema or hereditary angioedema is probably not the best way, and may end up with a needless ICU admission, needless procedure. So again, it's unclear what patient population in either ACE-induced angioedema will benefit from these drugs, but there probably is a very specific one that we can put these expensive drugs on and get a good, pretty bang for our buck.
Yep. Yeah, I agree.
All right, take us home.
So what do you do with these folks after you've got their airway managed or after you've treated them and they seem to be getting better? Well, unfortunately, there's no validated risk stratification tool. There is something called the ISHU criteria. I think I'm pronouncing that correctly.
It's actually a Scandinavian word. I don't know if you're familiar with that.
What does it mean?
It's a word that means fish eyeballs cooked over an open flame in a low moonlight.
The sad thing is I can't tell if you're kidding or not.
No, that's accurate.
Okay.
You can take that to the bank.
So that was a retrospective-derived set of criteria that they hope will predict who's going to do well and who's going to not do well. Unfortunately, it hasn't been prospectively studied. Now, this criteria is really pretty simple, and it's sort of it's very obvious, or it seems like it's obvious when you look at it. Patients with mild to moderate angioedema as manifested by maybe some facial edema, some lip edema, or a small amount of edema of the soft palate are probably okay to go home if they've been observed for a period of time to make sure they haven't progressed. Patients with lingular edema or laryngeal edema probably need to put in the ICU if for a longer period of observation, and that just seems intuitive to me. So I don't know that, like I said, that there's anything that we need more than that, to be honest with you. And again, I think a good dose of common sense when you're deciding on disposition of these patients
so you're
will
saying
probably keep you
drooling and stridor more severe?
Yes, that would generally
gotcha.
be
Sorry,
considered
I
more
wanted
severe.
To see where we were going with that.
You could probably watch them for an hour in the ED
yeah, you could.
And be okay.
What if you need to practice your cry skills?
Yes, exactly. In general, I think that if you are at all concerned about these patients or you're having a hard time knowing, are they more severe? Do I need to watch them longer than probably an emergent ENT evaluation or emergent evaluation from your intensivist so that they can actually visualize the laryngeal airway is probably the way to go.
I got to say, load the boat on these patients, man.
Yeah, I agree. I think it's better to have more people at the bedside than less people. This is not the time to these patients are not the ones to have the turf wars over. I would bring everybody you can to the bedside to help you out.
Anyone that's in-house, if you can get ENT, great. If you can get critical care folks, they're also very helpful.
Right.
Don't be afraid to make that. This entity tightens their sphincters as much as it tightens ours,
right.
and they're generally willing to hop into the fray.
Right. And then, obviously a surgeon, if you think you're going to need surgical airway and you have a surgeon available, certainly having them to back you up is appropriate. So that's pretty much everything that we have for angioedema. Thank you very much for taking the time to listen to this. I certainly enjoyed putting this together, and I know I enjoyed giving the talk earlier today at Obici, and I appreciate it. For those that don't know, Chris actually worked the midnight shift last night.
That's
and it's
right.
about 2:15 right now, so I know he's got to be dragging a little bit. But thank you very much, and certainly if you have any questions or comments, feel free to drop me a line or shoot me an email, and I will try to answer them.
If you guys want to know my secret, it rhymes with rack. Crack.
Oh, gotcha.
Yes.
Okay.
It's me.
Well, that'll definitely do it.
Yeah.
So.
Smoke crack.
All right. Well, thanks a lot, guys.